Well, it's 8 o'clock. We usually like to start right on time.
Let's
I
do
can't
it.
see how many people are here, Catherine, but should we just get started?
Yeah, go ahead and get started. This
Okay.
sounds great.
Well, for those who don't know me, my name's Farah. I'm a member of the Division of Hospital Medicine. It's a real pleasure to introduce Dr. Mark Shapiro this morning for what I am sure is going to be a fascinating presentation and discussion. Dr. Shapiro is a practicing hospitalist in Northern California and is the creator, producer, and host of the Explore the Space podcast. Explore the Space is focused on bringing healthcare providers and healthcare seekers closer together through conversations with thought leaders from a wide variety of relevant areas. Recent guests include Alia Bhatia, Executive Director of Vote ER, Sasha Shilcutt, creator of the Brave Enough Women's Conference, and Lindsay Fitzharris and Adrian Teal, authors of the very cool book Plague Busters. If you haven't seen this book, it's very cool. You should check it out. Dr. Shapiro is a two-time TEDx speaker, and his talk from July of this year, entitled Making Friends as an Adult, was selected as a TEDx Editor's Choice presentation. In addition to the talk he's going to give us today, which he just told us is the 20th time he's given this talk around the country, entitled Things I Didn't Learn in Training About Firearms, Dr. Shapiro also speaks frequently on topics such as gender equity, climate change, and disaster management. He's the winner of the 2024 Man of Good Conscience Award from the American Medical Women's Association and the I Stand With Her Award at the 2021 Women in Medicine Summit. As I mentioned before, he's also a clinician, and in addition to his work in this public arena, has been in full-time clinical practice as a hospitalist, working with the Providence Medical Group since 2016. And since joining that group, he's served as hospitalist medical director and as a member of the board of directors. He earned his BA in history at UCLA, attended medical school at Baylor College of Medicine, and completed his internal medicine residency at University of California, San Diego, UCSD. Thank you so much, Dr. Shapiro, for taking the time to speak with us this morning, and I'll turn it over to you now.
Thank you so much. What a lovely introduction. I really appreciate it. It was fun hearing you state back the most recent episodes that I've done on Explore the Space. Lindsay Fitzharris, for those of you who don't know, she is a brilliant author, and her husband is an animator. And they put together a young adults book on infectious diseases called Plague Busters. It was their newest book. Her first book is about the origins of general surgery around the world. Anyway, just a free plug for her because it's a fascinating book. The newest one is with Alia Bhatia about voter registration, and we'll talk about that at the end. It's true. This is the 20th time I've given that talk. I don't say that to like beat my chest. I say that to help us understand how the interest level in the topic of firearms, understanding gun violence prevention within the profession of medicine is rising. This is not because of my own little cult of personality. This is because lots and lots of really intelligent, really engaged people are realizing this is the right work, but we also need to expand very quickly the portfolio to talk about it. And I open with that, playing off of what Farah said, because for those of you who also have an interest in this subject matter, this is a place where you can make your career. The research to be done here is endless. The opportunities to speak, educate, learn, and communicate around it are myriad. And obviously, it is a critical time in our country to be doing this work. I'll move through the conflict of interest slide. I'll also just mention here too, I don't have any conflict of interest. If you want to share any of these slides on social media or anything like that, please feel free. Just tag me on Twitter at ETS Show. So the objectives for us for the next hour, we'll finish a little early because there's always time for questions, and there always are questions and comments for sure. We want to understand the implications of the Dickey Amendment. If you don't know what the Dickey Amendment is, don't worry, we're going to talk about it. We'll learn about secure firearm storage, and techniques to speak with patients about it. And then think about how we can, like I just alluded to, how we can begin to embrace our role, not just as physicians, not just as healthcare professionals, but as community members, right? As part of this extraordinarily heterogeneous mosaic of a country that we all live in to deal with the public health crisis of gun violence. A little bit of context. I'm not trying to recapitulate my CV here, but as far as saying, I got my degree in history at UCLA. The reason that's important as background here, I grew up in Northern California. The town that I grew up in was about 150,000 people, and there certainly were gun owners, but gun ownership and things of that nature were not a huge part of the culture that I grew up in. I did not grow up in a home where firearms were present, but certainly was discussed. They weren't like feared or anything like that. The narratives in this country changed. I remember when President Reagan was shot, and there was a lot of discussion about firearms and gun ownership. after that, and then obviously sort of accelerating from there. When I was at UCLA, I focused on 19th century American history and the American Civil War. And what I really learned in the 5 classes I had with one professor, that's when I really started to understand the primacy of firearms in American life and in American culture, as a tool for subsistence, as a tool for sport, as a tool for defense, the origins of the Second Amendment, and why that was such an important part of the Constitution of the United States. That was a very helpful time for me to understand, the way I grew up is not a representation of reality with perspective to firearms in the United States. And while this country is extraordinarily heterogeneous, there are massive swaths and large proportions of the population going all the way back to the origins of this country where firearms are a critical piece of their life. And it's not hyperbolic to say that they're a very, very important part of life for a wide variety of reasons. The transition, at least for me, started when I became a medical student. I was at Baylor College of Medicine. I'm sure some of you have been there or maybe trained there, something like that, like I did. Bentob is the big community facility, the big level 1 trauma center in the Texas Medical Center, and I spent a ton of time there. And it receives extraordinarily high numbers of people who've been victims of gun violence. So even as a medical student, just steeped in gun trauma. And I remember at the time thinking, this is really interesting. This is really cool. I'm getting to do procedures. We're learning all about, massive transfusion protocols and chest tube placements and all this stuff. But there was a gap. There was an absence of conversation around, like, why is this happening? There's a lot of this. And we're not really talking about any of the sort of origins. The juxtaposition at the time for me was around highly active antiretroviral therapy for AIDS, which really emerged at that time. And for that, it was, endless grand rounds and morning reports and bedside discussions and conversations and research paper after research paper. It was a very interesting juxtaposition because in terms of like how much we were seeing, they were kind of equal. When you're on your surgical rotation, all you're seeing are people who've been shot. When you're on your other rotations, you're seeing both. And it was really interesting to see that tremendous gap. And obviously, as scientists, we ask questions like, why is this the case? And I would invite you, as we sort of move through this talk, think about your own kind of background and where the conversations and narratives around firearms have been over the course of, college, medical school, your training, all of that sort of thing, and how it's informed the way you practice and the way you think about this issue. The same thing was at UC San Diego. Still seeing plenty of people who'd been shot, but also seeing more as an internal medicine resident, the short and long-term sequelae, bowel obstructions, wound infections for people who are quadriplegic, traumatic brain injuries, really catastrophic things that have happened to people that is a direct result of them having been shot recently or in the past. And again, still no conversation around it. And I don't say that to impugn anybody. I love where I trained. I love the people I trained with. These are amazing facilities. This is a reflection of the time in which I trained. And it's that juxtaposition that's just so powerful. The title of this talk is really important to learn versus taught. This is stuff that I learned. It was not what I was taught. That is intentional because for me, I still work very hard at not being conflict averse. But in training, avoiding conflict was something that was helpful, a much more comfortable place for me. I remember very specifically having conversations or having people telling me, do not talk about firearms, do not talk about gun violence aside from where are we putting the chest tube. We'll get in trouble. You'll get in trouble, you'll get censured, it's unprofessional, it would be bad for your career, don't do it. That was made very, very clear to me. And that really stuck. You don't want to hear those things early in your career about specific subject matter. The one thing I remember hearing in medical school when I gave this talk back at Baylor, one of my classmates was there and they remember this too. It was just before Memorial Day weekend and the professor was wrapping up the lecture and said, I just want to remind all of you, hope you all have a great holiday weekend, but just remember, half the people on the road have a gun in their car and half of those people are drunk. Good luck. And I remember we all looked at each other like, what was that? But that was like the extent of our training around firearm safety when I was a medical student. And that was quite a thing. And then again, that juxtaposition, right, of like, where is all of the conversation around this thing that we're seeing so much of? And the reason for that is the Dickey Amendment. And for those of you who don't know what the Dickey Amendment is, this is the thing. This is why we weren't talking about it. October 7th, 1993, this paper comes out in the New England Journal of Medicine. Gun ownership is a risk factor for homicide in the home. Dr. Kellerman is still very active. He's been on Explore the Space podcast. He's remarkable. This was a well-designed case control study looking at multiple different states. And what they found in this paper was that owning a gun and having a gun, let me step back. In this paper is the presence of a gun in the home, not ownership, but just whether the gun is in the home or not, is associated with a fivefold increase in the risk of homicide, not accidental discharge, not death by suicide, murder. And this was a really important paper. And this is one of those things that when it comes out in the New England Journal of Medicine, we think to ourselves, this is practice changing. This is a big deal. There's momentum that comes from this. And the idea behind these things is this is how we help people make the right decisions for themselves and their families to keep themselves safe. It met with extraordinary backlash. For those of you who were around in 1993 and thinking about these things in 1993, this was a very interesting time in our country as the National Rifle Association had really changed how it was lobbying. But this was also in the wake of the fights to get labeling and appropriate warnings in place for tobacco. And so what the National Rifle Association did is they started to go after the funding for this sort of research, because this is obviously, right, this flies in the face of the narrative of more guns are better, they confer protection. But if we have hard evidence that says actually that's narrative, that's marketing, but the reality is fivefold increase, that's a problem when you're coming from that perspective. So the NCIPC, the National Center for Injury Prevention and Control, is funded by the CDC, and the NRA publicly adopted the position that firearm-related injury research was, quote, research advocating gun control and anti-gun advocacy. The terms gun control had been around for a while, but this was a real pivot point. This is where it became this firebrand term, and this binary argument was established around gun control. They tried to get the NCIPC failed at the level of the United States Senate, and that failed. But it didn't end there. And there was a subsequent interview with Dr. Mark Rosenberg, and I'm sure some of you probably know him. I've had people who've been guests listening to this presentation who worked for the NCIPC at the time and obviously know Dr. Rosenberg. It's really interesting to hear their reflections. But basically at the time, the message was you can either do research or you can keep your guns. But if the research goes forward, you lose your guns. That's that binary argument that we hear now. And it's become this sort of fever dream that somehow anything to do with looking at firearm safety is going to mean some entity will come into your home and take your guns away, which is obviously not the case. But that's a very provocative form of public discourse, and it was very, very effective. So from that, in 1996, Congressman Jay Dickey, who was a junior congressman from Arkansas, put the following language into the 1996 Omnibus Consolidated Appropriations Act. It's the money. It's the budget. Quote, and this is a horrendous sentence for those of you who like that stuff, and I'm kind of pedantic when it comes to grammar, so this one drives me nuts. Let's read it together, shall we? That none of the funds made available for injury prevention and control at the Centers for Disease Control and Prevention may be used to advocate and promote gun control. I think it's purposely obfuscatory. It's really weird. It's a strangely crafted sentence. It's a run-on sentence. It's full of verbiage. It's impossible to determine what that actually means. The other interesting thing about it, I was a sports writer when I was in college, and there's a term for when you have a story that that you're going to publish, but you don't want a lot of people to see it. It's called burying the lead. You put it somewhere where you don't think people are going to see it. I was a history major, so I had to go for the primary source. There's the Dickey Amendment highlighted in blue. Page 244 of a 766-page document. It's right above a paragraph about the Bureau of Mines. This is the definition of burying the lead. This is something that they did not want people to see, and they tucked it away next to the Bureau of Mines. It's not a very big bill either. It doesn't really do much. It takes $13.1 million that were earmarked for firearm injury research and transitioned it to traumatic brain injury research, which on the surface, it's like, well, $13 million in the federal budget. I mean, that's a nothing burger. However, it's the vagueness of the statement that made it so powerful. As Dr. Kellerman said, precisely what was not permitted under the clause was unclear, but no federal employee was willing to risk his or her career or their agency's funding to find out. Extramural support for firearm injury prevention and research quickly dried up. So this is 1996. Think about when you were training. This is a de facto gag order that then now falls on our profession because people really were afraid that they would lose their jobs, they would get fired, they would lose their funding. It's this vague thing where there's really no clarity around it. And the stakes were very, very high. And again, people have come up to me and said, yep, that's exactly what happened. We were told do not talk about guns aside from where to put the chest tube because we don't want to lose our funding or we don't want to lose our jobs or get in trouble. The stakes really were that high. So from 1996 on, the curtain comes down. It didn't end there. In 2011 in Florida, a law was passed called the Florida Firearms Owners Privacy Act. which blocked healthcare professionals from asking patients and families firearm-related questions. Tell me if this doesn't resonate today. Physicians in violation faced fines, sanctions, or loss of their license. In 14 other states, similar legislation was put forth but did not pass. In 2017, this law was overturned by the the 11th Circuit Court based on a lawsuit filed by the American Academy of Pediatrics. It's a really interesting piece of legislation. I'll invite you to take a look down at the bottom. You'll see the link there to read it yourself. Normally, if you ever read a piece of legislation, it's very flowery, right? Lots of wheretofore and hereforth and forthwith and things like that. This is like one page. It's almost like a really bad infographic. It's got like 8 bullet points and that's it. So it's this really almost like cursory thing. But again, there's something in it that's very, very interesting. And I get asked a lot about what would be the things that would help drive change. Well, if you look at this piece of legislation, they kind of give away the game a little bit, because one of the line items is this law also forbade Florida insurance companies from using anything to do with firearms in any actuarial tables, life insurance, liability, auto, home, anything. You couldn't account for firearms. That's a big deal when they're sticking that into this law as well. So anyway, it's worth looking at because it's a pretty fascinating piece of legislation. So the fallout, the Dickey Amendment is actually still on the books. In 2018, many of you probably remember this. The Dickey Amendment was reinterpreted, so the CDC can conduct research around gun violence, but cannot use government appropriated funds to specifically advocate for, again, this weird term, gun control. $25 million was the initial appropriation in 2019, and it's gone up from there. And we've started to see more and more things, but this epilogue still holds, and this statement still holds. U.S. scientists cannot answer the most basic questions: what works to prevent firearm industries and what's firearm injuries? And the problem is, right, we know that nature abhors a vacuum. So on one hand, there's this constant stream of we need more. We need more guns. We need open carry. We need no background checks. We need high capacity magazines, et cetera, et cetera. There's no good countervailing argument. Those arguments prey on fear and marketing and machismo and all these different types of things. But on the flip side, we don't have the ability to say, well, actually, those don't work, and here's why. It just feels like opinion, as opposed to being able to say, well, there's this paper from 1993. We all know that in our profession, in 2024, if you bring up a paper from 1993 as your like main argument, everyone's going to say, look, it's a good paper and all, but that's 30 years old. Like, we need stuff that's a little more recent. Society is very different today. These things haven't been studied for 30 years. And here's the more interesting thing about this statement. This was an editorial in the Washington Post written just after the Aurora movie theater shooting. And the author was Congressman Dickey. He wrote it along with Mark Rosenberg, and up until the day he died in 2017, he decried his own amendment, and he did it publicly. This was a terrible mistake. It was way too vague. We never intended for these sorts of consequences. Whether those are crocodile tears or not, I mean, no one will ever know the sort of like dealings and planning behind the Dickey Amendment back in 1996. But it's uncommon for a member of Congress to decry their own legislation as loudly as he did in the wake of the Aurora movie theater shooting. So here we are, 30 years have elapsed, right? And in January of last year, Dr. Ranney, who's now the dean of the School of Public Health at Yale, wrote an editorial, "We need more research on guns. Here are 5 questions we can answer." We could have been answering those for the last 30 years, but we weren't able to. So that's a big gap, but we get to use that as our starting block. For those of you, as an aside, who don't know Megan Ranney and her work, you should look her up. She is one of the real titans of American medicine. She's been doing work in gun violence for the bulk of her career, and I've learned so much from her. She's just an absolutely extraordinary person, a brilliant leader, and a wonderful physician. Here's where we are. The U.S. Surgeon General's advisory that came out a few months ago: gun violence is a public health crisis in America. These are not negotiable statements. These are not debatable facts. This is where we are. The sooner and faster we accept that and use that as our launch point for progress, the better off we're all going to be. Firearm homicides are up 33.4% from 2019 to 2020. Deaths in general up 13.5%. And then for the age group 1 to 19, 29.5%. And here's the part that's the most troubling. I know you all are aware of this, but we don't take anything for granted. The leading cause of death for children in the United States are firearms. And this is the graph that we all have to live with right now. This was from the New England Journal of Medicine from, I think, about 2 years ago. It's been updated since, but this is the one that came out that really grabbed everybody's attention. If you look to the right, there's firearm-related injury, and it is like a 60-degree angle up. I have an 8-year-old. It's a little bit difficult to still wrap my mind around the fact the most likely thing that would take the life of my son is a firearm in this country. There's a whole bunch of other things on this chart, and all their curves are doing different things as well. But this is the one that we have to live with. This chart, this graph sucks. It's inexcusable. It's gross, and we all have to take ownership of it, not just as physicians, but as a society, and say this is entirely unacceptable. What do we do to make this different? And when we zoom in on it and we look at these other things, it's important to keep in mind there's a bunch of other things here, right? And we're not in denial about those. For each of these, there are a wide variety of interventions and advocacy groups and research dollars and attempts, failures, improvements, exacerbations, but an ongoing effort at improvement. And you can see a lot of these lines have come down. You don't need a grand rounds to go through these other things and think about the myriad interventions taken for all of these things for children and for adults to try to make them better. The perfect example in 1983, there was the contamination of acetaminophen in Detroit, and 8 people died. And if you want to put it in the chat, I'll just tell you, this was, for those of you who don't know, there were 8 deaths over the course of like a week from these contaminated bottles that somebody had messed with and poisoned. That's why we have safety caps. That was the intervention, this massive intervention, very, very quickly. That's why we have the child-proof safety caps on all of our pill bottles now. So we as a society can do that. We think about drowning, right? We've got pool covers and fences and lifeguards. We have so many different things around that. Again, that juxtaposition, right? That gap. We don't have that yet, that battery of interventions and that robust discussion and totally normal conversations when it comes to firearms. When a survey was done recently, and this is from the Surgeon General's report, 54% of U.S. adults report that either they or a family member have experienced a firearm-related incident. And you look at the right, here's the respondents. There's one that's missing, and this is the one that's important for us. Every single member of the profession of medicine has been affected by firearms. So that changes these numbers to up, because I wasn't pulled, and you may not have been either. Every single one of us has been a part of it because we've helped take care of these people. That's a domain that wasn't researched. That's not a criticism. It's just an acknowledgement that this is a significant undercall. So when we think about the people who've been exposed to it, I can still clearly see and hear everything around the people that I took care of who've been shot, who died, the conversations with their family. Those things are really affecting. Those things happened in my 20s. I can close my eyes and hear and see all of it. And it's hard. It's really hard. It's just a part of our profession, but that needs to be acknowledged as well. So we take all that on board and we think to ourselves, how do we start, right? Well, we have to first own the fact that we start from where we are. Where we're starting from right now is this lecture. I didn't get this lecture in medical school or residency. We're doing it together today. I know there's other people at your institution that do wonderful work on this. There's a lot of other people around the country. This is where we start. The first thing is we have to shed these old mindsets, right? The idea that this is somehow unprofessional, that we're going to get in trouble, that this is the wrong thing to be doing. This is a CME talk. It meets CME criteria. I've done it 20 times all over the country. That much pushback, zero, none. Everyone said, "Yep, all these slides pass muster. Let's go." That's where we start from. That's the new reality that we deal with. The place to start that I would argue that we can start with literally today, when you go back to making rounds or go back to clinic, is thinking about secure firearm storage as an injury prevention strategy, and then think about ways to use your megaphone. We all have one. Dr. Mona Hanna-Attisha, who is a pediatrician in Flint, Michigan, who exposed the lead contamination in the municipal water supply. She came on Explore the Space podcast and she said, Mark, physicians carry a megaphone and have a responsibility to use it. And that really stuck with me. So that's the springboard. We shed our outdated lessons. We start with secure firearm storage because we can do that today. And we own the fact that we have this megaphone. And this was a really galvanizing moment for a lot of us. And when I say a lot, I'm talking many, many thousands of American physicians and healthcare professionals. This was a tweet from November 7th, 2018, in response to an editorial in Annals of Internal Medicine about gun violence prevention. This is the stay in your lane tweet. And the response to this from all around the world, this was when, med Twitter really was at its apex, was really striking. A lot of people just came out and said, people who weren't even very active on Twitter, like, this is completely absurd. This is all I do all day, every day. This is absolutely my lane. For me, this was a really important moment too, because I saw a lot of people being very courageous, sharing stories, being very transparent, in a way that I had always been told if we do this, we're all going to get in trouble and we're all going to get fired and we're all going to be, deemed unprofessional. So this was a really galvanizing moment for me too, to say, hey, wait, if these people are being this courageous, I can do the same thing. And I can use my platform and my voice, and I should, because this is my lane. So we transition from this idea and this robust response and knowing that we're not alone in this work to thinking about secure firearm storage. On the left is a tweet, which is a really important starting point. We can look at it and we can say, well, as an internal medicine physician, as a hospitalist, I can probably make some thoughts on sleep hygiene here. 4 caffeinated beverages at the bedside. We know that caffeine before bed's not ideal. But then we also look at the firearms that are present. One of them is a Revolutionary War era pistol. That's not going to be an effective tool for home defense. It's probably a display tool. You could fire it, but you would need dry powder, you would need wadding, you would need a musket ball. That's not what we're looking at, but it's the revolver underneath it that is pretty striking. It's a very powerful weapon. I can't tell if it's on safety or not. It is not secured. It's just sitting out. It looks like it's loaded. I can't really tell, but I think it is. And certainly in the way the tweet was promulgated, you're kind of given the impression that it's loaded. It's really important when you look at that. And if you look at the picture on the right of, unintentional firearm deaths among children and adolescents, the other thing to remember about something like this, if you were to discharge that in a standard bedroom in a home built in America, the walls of that bedroom are not going to stop that bullet. And that's one of the terms in firearm training of knowing your background, that if you're going to discharge a firearm at a target, you have to know what's behind and beyond the target, because you're still responsible for it. And that bullet doesn't care if there's some balsa wood or a 2x4, especially from that hand cannon, it's going to fly right through them and hit something else. And that's a really important part of this discussion, is how people get hurt and killed unintentionally, because the bullet's going to fly through the whole neighborhood. We look around where these things are, right on top of the nightstand, under a mattress, on a bed, or under a pillow, and we think about that spectrum of what is secure firearm storage. The firearm is unloaded, the ammunition is kept separate from the firearm, and the firearm is locked. And there's different types of locks. We'll look at a couple of them. In one study, 46% of owners reported following even one of those practices, but it is a continuum, and we want to remember, as we're thinking and talking about this, 1 is better than none, 3 is better than 1. We're looking for all components of this, but any component of it, of secure firearm storage, is better than nothing. So here are gun locks. And when we look at the taxonomy of firearms, there's 3 major classes, and many of you know more about firearms than I do. But I also know that we don't want to assume knowledge, and this can feel a little bit weird to talk about. I fully acknowledge that. 3 major classes. On the left are pistols. Pistols are handguns, of which there are thousands of different types. In the center are shotguns, and on the right is a rifle or a long gun. The one that we see here is an AR-15, which is a semi-automatic assault rifle, but there's a wide variety of other types of rifles or long guns. The breakdown from there makes the coagulation cascade look like absolute child's play, trying to remember all of the different types of firearms that there are out there. But the fundamentals of a gun lock are pretty consistent. Basically, what you're doing is you're interrupting the ability of the weapon for a round to go from the magazine into the chamber and from there be discharged. You can't see where I'm pointing, obviously, but if you look at that rectangular hole where the arc of that is, that's the chamber, and then below that is the magazine. So you don't see the clip on the AR-15, but that's where a clip would go, right where that piece comes down. In the shotgun, you load it right underneath the chamber in front of the trigger, and then the pistol, you would load it from the handle. And when you put a round in the chamber, when you pull the trigger, the pin shoots forward, it hits the back of the bullet, the powder ignites, and the warhead flies downrange. The gun lock interrupts that. You cannot put a round in the chamber when you have a gun lock, and this is basically like a bike lock. It requires a couple of things. It requires dexterity, it requires vision and coordination. It requires some fine motor skills, certainly, to unlock it as well. They're not very expensive, but we have to remember, if you want to buy one on Amazon, you need all the things to get it on Amazon, right? You need a credit card and an address, but $20 is $20. And that's not cheap for a lot of people, but that's what a gun lock looks like. There are myriad other brands that are far more sophisticated. Interestingly, there's one with this thing called gun safes, where you can leave your firearm in a safe. The safe is opened with a thumbprint or sometimes with a retinal scan. The biggest brand underwent a massive recall because there were a couple of deaths where the safe wasn't locking and kids were getting to the guns, and there were some deaths related. And the irony, of course, is Massive intervention was taken. Oh my gosh, we have to make this better. This is unacceptable. The safes were recalled. Nothing to do with the guns, God forbid, but the safes were recalled. How are we as a profession doing with screening? And this is a question that we have to ask ourselves. 14% of adults have been asked by a healthcare professional if they own a gun, or, very important distinction, live in a home with a gun. And the reason it's an important distinction, if you ask someone, do you own a gun? No. Well, you haven't resolved the puzzle fully. Do you live in a home with a gun, or is there a gun present where you live is a different question. It doesn't presume ownership. It doesn't presume legality. It's just, is there one nearby? That's a different question. 26% of parents say their pediatrician has asked the same. Our pediatrician's office does screen for firearm ownership. 5% of adults say a healthcare professional has spoken with them about gun safety. 5%. This is our opportunity for improvement. And this is the good part. We are the best in the world at screening. There is no one better than all of you. We screen for everything, and we're good at it. We're persistent. We're thoughtful. We're empathetic. We're smart. We're well-trained. This is no different than the screening that you do talking about colorectal cancer, talking about STIs, talking about mental health screening. It is no different. When we think about the fact that half of Americans live in a home with a firearm in it, there's more guns in this country than there are people living in it. We have to think to ourselves, how often are we asking about firearms and secure storage? I'm still getting better at this. I'm not perfect at it. I don't remember to do it every time. But it's difficult. How do we feel answering questions, providing resources, and dealing with resistance and frustration? This is my story about this. So I was a resident and the interns were off. So it was me and the attending rounding at the VA in San Diego. And we're going to see this older person, and the daughter comes out and says, I need you guys to talk to my dad. We're really worried. We know he's getting ready to be discharged. There's guns in his home, and we're really, really worried about it. We need to talk about it. And my attending and I looked at each other like, oh no, because neither of us had any training, none training, zilch about this. And the irony is that the VA is the best in the world at secure firearm storage, and the military, there's no entity that's better about secure firearm storage and firearm safety training. You can imagine the conversation with this patient went very, very poorly. The attending and I both really didn't know or have any training in how to manage this. The patient got very upset and defensive very quickly. The conversation could have gone much, much better. This is why we learn and we train around it. The other question is, do you know how to get a free gun lock for your patient? We should be able to write for gun locks as DME, in my opinion. However, are there ways to get them for free, right? We shouldn't assume that people can just get one. When I've called the Santa Rosa Police Department or the Sonoma County Sheriff, as soon as they get them, they're gone. They do gun lock giveaways and things of that nature, but they can't get them in fast enough because the demand is so high. So and I would ask people to put in the chat box, because there's always ways. Now you can get one at the VA. At the VA, you can get gun locks, but if you're not working in a VA and you have this conversation, they say, you know what, I need a gun lock. Are you going to say, all right, cool, go to Amazon and good luck? Or can we figure out a way to get you one quickly? Again, this idea of how are we doing with screening? It's the same as you do with all of these other domains. And here's some tips around language. If there's firearms in your home, how are they stored? If the person says they're stored safely, expand on that a little bit. And if they say they're not, just opportunity for effective basic counseling. And remember that if there's frustration or defensiveness or any of that sort of thing, you just move through it like you do for anything else. If they don't want to talk about it that day, that's fine. Sometimes people don't want to talk about smoking cessation, and that's okay. It doesn't mean that we don't do it again. But the other thing about it is this is just part of your domains of all the different social determinants of health. There's no like talking about access to food and transportation and how are you getting home, and then, okay, hold on, time out. I need a drum roll because now we're going to talk about this really controversial topic of guns. That's not the way this works. It's just part of the same discussion. And I can tell you, and for me, having had these discussions now over the course of several years, I've never gotten pushback. Not once. Not once. I've had people say, I don't want to talk about that. Or, yeah, I've got guns in the home. They're fine. Can we expand on that? No. Okay. But I've never had someone say, you shouldn't have asked me, or why are you asking me that? That's not to say that may not happen. But everyone knows that this is a problem in our country, and they are waiting for us to ask them and to talk about it. As we're doing this work, looking for risk compounding factors is absolutely critical. These are things like histories of domestic violence, histories of violence, history of mental health issues. And the reason that that's important is those who have a mental health diagnosis are more likely to be the victim of gun violence, not to be the perpetrator of gun violence. This is a very common canard in the ongoing debates about guns in this country. But mental health diagnoses make you more likely to be a victim of gun violence, not a perpetrator. And again, as you're doing your screening, this is the same as you would for anything else. You don't have to reinvent the wheel. And one of the asks from this talk is to start today. When you go back on rounds, you go back to clinic, try it. Just try and see how it goes. Come back to your teams, come back to your huddles, come back to the group and say, I tried it. This is how it went. This is what I felt like worked. This is what didn't work. This is what the person said to me. That's how we begin to normalize it. That's how we build a bit of momentum. We assess interest, we seek understanding of their unique context, we offer solutions and shared understanding, and then we provide choices and follow-up. That's the part that is really critical, but it's the sharing of your stories and your experiences as you do it that drives progress. Super important things to keep in mind. Communication barriers, just like with any other type of screening, nothing different. Do they have their hearing aids? Do we need translation support, things of that nature? Be mindful of your own implicit biases. This is not just to like satisfy the, are we discussing implicit biases in this talk? This is absolutely critical. Every one of us, and this is not a criticism, we have been saturated over this whole arc of our lives by different representations of guns and gun violence, those who perpetrate, those who are affected by popular culture, by the media, by social media. We have been saturated by it. That saturation leads to implicit biases. You have to take ownership and take stock of those as you go forward and be very, very mindful of how they impact the words you choose, what you put in the medical record, how you think about this issue, because they're there. That's not because you did anything wrong or I did anything wrong. This is what happens when you are sprayed with the fire hose of media that we are all sprayed with from the beginning. And obviously firearms are a big issue in all of those spaces as well. It's also really important to use the sort of appreciative inquiry. If somebody says that they keep a loaded firearm by their bed, why? Help me understand, why is that for you? Not that's stupid and you're gonna kill somebody. It's help me understand, like, why is that important to you? And then you can hear their story and understand why they may feel the need to do that, and get a better understanding of the place that they're coming from, and then try to meet them there, as opposed to our implicit biases leading to judgment around the decisions that they're making. We are trying to help people make the best decisions for themselves and for their families. We have to meet them where they are, and this issue is absolutely no different. And the ask, you can start this today. There's no reason to, you're all going back to work after this conference. Try it, seriously. And you can email me, you can send a message to your teammates, whatever it is, but normalizing this is super important. I would ask you to try to avoid saying gun control. I actually learned this from Steve Kerr, who's the head coach of the Golden State Warriors. He lost his father to gun violence. He came on Explore the Space podcast, and he basically was like, Mark, if you say the words gun control, you've lost the argument immediately, because you have fed into this fever dream where you are now in the space of taking people's guns away. In the state of California, I don't have that power as a physician. And I would imagine it's the same in the state of Wisconsin. We don't have the power to take someone's firearms away. We are able to provide counseling. Here's some other terms you can use, but when you say gun control, you've kind of painted yourself into a corner right out of the gate. There's lots of other very effective terms you can use that don't trigger so much response baked in from the last 30 years. Because I'm a hospitalist, because we're internal medicine docs, we have to have case reports. So 48-year-old hospitalist who's going on service soon, specifically about 25 minutes from now, at a level 2 trauma center in Northern California. I've had the opportunity to understand more about gun violence in America, and decides he wants to speak with the patients about firearms. What are good resources to build communication skills? So there are some good resources out there. The best one is the Bullet Points Project. I have no conflict of interest. I don't work with them. I just know of them. It comes out of University of California at Davis, and it gives all of the wonderful vignettes, case studies and resources for kind of specific places to be around firearm injury. And it's totally helpful. It's totally useful. And I would recommend taking a look at it. It's free and it's open source. But I've also found, having done this talk many times, there's always resources available. The University of Wisconsin probably has some sort of resources, or a community violence intervention program or something like that, that there's just an opportunity for more people to know about. So if there are those resources, I would really invite you to share those in the chat field. But the Bullet Points Project is a really good place to start as well. I was fortunate to be able to help write this article that was published in the Journal of Hospital Medicine on catalyzing action around preventing gun violence. And the crux of this one was helping people understand the importance of calling your elected officials to share your opinion and how that process works, specifically around subject matter as it relates to gun violence, as more and more legislation comes forward, because your voices are heard. There, you will always speak to a staffer or be able to leave a message, and they all do keep track of it. And the other thing about this is it helps break that sense of inertia, of when you're feeling like I don't know where to start or I don't know what to do. You can break through from that platform. Our second case, and this is something that this is our family's, our son was having his birthday party. We want people to have that sense of security coming to our home. We know that we always talk very easily and readily about, are there pets? Are there food allergies? If there's a swimming pool, like how is it protected? Are we going to have a lifeguard? Along that same line and through that same spirit, we just include, where's a good place to start to normalize these discussions? We just put in the invite, there's no guns. It's just part of the discourse. And it's really interesting having brought this up. This is also one of the parts of this talk that engenders a lot of response where people have shared stories with me. One of my good friends, when I gave this talk in San Diego, and he gave me permission to share this. My son has Down syndrome, and he's very, very curious, and he likes to look around in homes where we're visiting, and it occurs to me he could very easily find a gun. And we've never really asked people when we've gone to their homes, is there a gun and how is it secured? And we really need to be doing that. These are the questions we should all be asking each other. There's nothing wrong with it. We're all thinking about it. But as a community, having normalizing the subject matter, there's no judgment around just, is there one there? Yeah, we have a bunch of firearms. They're all loaded. I keep them on display. They're super fun. Then you get to make a decision about, is that the right place for you and your family? Or yes, we have a variety of firearms. They're all locked. They're behind a safe. They're in a closet where I have the key. That's a different conversation. Obviously, those are extreme examples, but that's the normalization of the discussion so that we can make the best decisions for ourselves and for our families. The last piece about this is this issue of us being divided on the subject. We're not. This country is not divided on the subject of reasonable actions to reduce gun violence that do not violate the Second Amendment of the Constitution. I'm a history major, and I would ask any of you, if you can go back since Pearl Harbor, since December of 2000, since December of 1941, can you find me anything in American history since Pearl Harbor and entering the Second World War that pulls at or above 80%? If you can find one, you'll be the first. Here's 5. That is not the standing of a divided country. We're told we're divided on this subject, but we're really not, on these issues of rational interventions to reduce gun violence. Here's 5 of them. So it's important that we keep that, because we can gaslight ourselves into, I don't want to talk about this. We're divided. It's controversial. Most people really want to see these things and would welcome discussion as an extension, right? It would welcome discussions about how to actualize these things for themselves and for their families. Last thing, and I end all my talks with this, is to discuss voter registration. Voter registration, speaking of social determinants of health, has been deemed a social determinant of health by the American Medical Association as well as HHS. Healthcare professionals, physicians specifically, usually vote between 12 to 20% less than the general public. In the last general election in 2020, that was better, but it's still not where it should be, because every local, state, and federal election, there are things that pertain to the way we deliver care and the way we try to take care of people in our communities, that we should be able to have our voice heard on. Whether they're candidates or bond measures or whatever the case may be. So it's really important that we are all registering to vote if we're eligible. This is a QR code that takes you to vote.org. Vote.org is nonpartisan. It is not for profit. You will not get any spam. You don't have to enter a password or an email. It'll take you between 90 seconds and 2 minutes. And what you can do here is you can register to vote if you're not already registered, and you're eligible. Or, and this is also very important, you can change your address. We're a very, very mobile profession, and that's been a barrier for a lot of people for a long time when it's been studied. People forget to change their address. And so you need to make sure you're registered in the right precinct so you can vote in the right precinct. The other part of this is you have to make your voting plan. For election day, are you going to vote absentee? Are you going to have a ballot mailed to your house that you can fill in and put in the mail? Got to remember with those, they have to be postmarked on or before election day. If it's postmarked after election day, it will not count. And that's the same nationwide. California is an automatic absentee ballot state, so we automatically are absentee. You can opt out of it and vote in person if you want to. Wisconsin, I'm not sure, but you would have to pick it. The deadline's coming up. It's in a couple of weeks, so register today for sure. And then the other part of making your voting plan is if you're voting in person, check your schedule. If you're on call in the ICU on election day, it's going to be difficult to get out and get to your voting precinct. So talk with your friends and your colleagues. If you really do want to vote in person and you're working, how are you going to actually make that happen? Because you don't want it to be like the polling places are all about to close and you're still stuck at work and you're not going to get to vote. All of these things come down. Everything always comes down. They're always very close. So making sure your voice is heard is super important. What I always ask people to do, whether I'm in the room or virtually, take a picture of this, take a screenshot of it, all of you, and then you can share it. If you are not eligible to vote in this country, that's totally fine. We want your participation. You can still help to normalize these discussions, still share the QR code and encourage your teammates to vote. Maybe you can cover somebody for 2 hours so that they can go and vote, and then they can, get you lunch or something like that. But again, making this part of just our team tapestry is super important. But from this springboard, we can really begin and stepping into this tension. And I thank you for doing it with me. You can really think about formative parts of your career. You can certainly begin talking about patients, talking about secure storage with patients, but opportunities to make this a part of your career are right there. The research that comes out of the University of Wisconsin is endless. And if you were to say, you know what, I want to start doing some research around screening, or I want to look at how we're doing around any of these different domains, start doing it and it'll get published and you'll get to give talks on it. And it'll be a real driver of your career and something you can feel really good about. But again, it's this idea of how do we begin to normalize this to drive progress is what is so important. So I appreciate you all being here with me. Here is the link to the session evaluation. I'm happy to stick around to answer questions. But again, this was really wonderful. Thank you all so much for having me.
Thank you so much, Dr. Shapiro. I found that fascinating, and I know a lot about this, but just hearing the personal, like your personal experiences at Ben Taub and how that kind of continued to drive you through your career is so interesting. One of my friends says, when you're working, pay attention to what bothers you, pay attention to what annoys you, and that's probably an opportunity for change. There are a couple questions in the chat, or in the Q&A. One is actually a comment, and it says, Dr. Shapiro mentioned he can't tell if Musk's weapon is unsafe. It's important to note that many weapons don't actually have a manual safety as we think of it, meaning they don't have a switch or mechanism you have to engage before being able to fire, pick it up and it's ready to fire. I didn't know that. Is that true about a lot of guns?
This is all still part of my learning. I think that
Yeah.
that wouldn't surprise me. I wouldn't say that I'm an expert. Where did you see it? Is that in the chat or is that somewhere
It's
else?
in
I
the
just didn't see it.
Q&A. You have to click on the Q&A
Oh,
button in the
okay. There it is. I
bottom.
see it.
Yeah. Yeah.
Got it. Yeah. I absolutely believe it. And I don't know how many there are and I don't know how to tell.
Yeah.
I haven't had specific training around that, but I do know that one of the things that, in the training that I've had, is that every gun that you see is loaded and ready to fire. That's the assumption. You always assume it is loaded and it is ready to fire. So you don't pick it up unless you intend to fire it. You never aim it unless you intend to fire it, because every gun is loaded and ready to fire. That's the assumption when you come in contact with one. And that's what we need to be teaching everyone that comes in contact with a gun. That thing is loaded and it's ready to fire. And so act accordingly. So get away from it, notify someone about it, but don't pick it up and start aiming it, because until proven otherwise, loaded and ready to fire.
And the other question here you might be able to see, are we as physicians allowed to contact law enforcement to report irresponsible gun storage by a patient?
That is state by state.
Yeah.
The laws of Wisconsin, I don't want to pretend to be able to speak to them. What is irresponsible gun storage, and also what is so irresponsible, right? That we have to be a little bit careful, because we don't want to cast judgment. They're doing what they're doing, and it's not illegal. So if they decide to keep a loaded firearm that does not have a safety catch next to their bed, I don't think they're breaking the law in Wisconsin. If they were to say that I have this gun at home and I intend to use it on another person or on myself, I would imagine that you have a responsibility to report that. But when you're learning about how they're storing their firearms, I don't think that there's if they were to say that that's how they store their gun, they keep it loaded by their bed. I don't think that there's anything to report, because I don't think they're breaking the law. I don't know, but these are really important questions for us to know what we are and are not supposed to be reporting.
And Siobhan Wilson is a colleague of ours who does a lot of work in gun violence here at UW. She's amazing. And so she is putting a link in there from the Gifford Center so we can look and
Oh,
see.
good. Okay.
People can look and see.
And that's one of the challenges, right? There's so much interstate variability around this, and there's a lot of confusion, and we want to do the right thing. It becomes very, very challenging for sure.
I was just thinking about your I wrote down a lot of questions, but you answer a lot of them, particularly about like asking parents when your kids go over to play, like when your child goes to somebody's house, do you ask them, are there guns in the home? And I think a lot of people don't, and it feels so awkward, but I think you're right. We just normalize it, right? I mean, how do you do that? You've got an 8-year-old.
Yeah, it's just trying to remember to do it and then not being mad at myself when I forget,
Yeah.
quite honestly.
Yeah.
But it does feel awkward and it's weird, but we want to be in a place where it's not, because it doesn't feel awkward to ask about dogs or peanut allergies or
Yeah.
swimming pool security. It's the same thing. It's what are we doing to try to keep our kids safe when they're in a different environment?
Yeah.
And we do it for all these other domains. This is the one that is the most likely thing to cause death. We should be doing the same work, but it's not easy. There is a comment from Catherine in the chat that, like we talked about briefly, the VA is really good about this. And there's some links there from the VA,
Yeah.
and there are gun locks available for free, so that's really good.
And then in terms of like legislation, if we want to do more, and so I mean, clearly there's a lot for us to do as physicians on the individual patient level, but if we're interested in trying to do more in terms of you know, bigger picture changes, do you have any thoughts on like working through legislation versus working through like local policy, trying to change things maybe in your healthcare institution or I don't know, in your healthcare system? I don't know, thoughts about that?
Advocacy takes many forms, and the most important thing is to do what feels right and authentic for you. And that's not a platitude. I'm not opting out. I think trying to shoehorn yourself into something that you think is going to be big and right and powerful may not actually be the most effective because it's not going to feel right for you. If it feels good to just start off by calling your legislators and sharing your opinions, that's awesome. That's a huge step in the right direction. You're absolutely allowed to do that as a healthcare professional. You're a citizen, you're a part of this country, you pay taxes, you're supposed to do those things. That's civic engagement. You're not going to call them and say, I work for X, Y, and Z, and these are all you don't have to do that. You don't have to say anything except like, my name is Mark and I'm a constituent. That's a really good place to start. I don't, there's so many other things that people can do. But it's just about picking the ones that feel right and feel authentic and then sustainable, because it's not like tomorrow we're going to wake up and this is all better. This is work we're going to be doing for a generation, and that's fine. That's how we drive change. It takes a while. And so finding a place where you can kind of dig in your heels and work and have it be sustainable and effective, hopefully going forward, and also be something where you can role model for other people and bring more people aboard. All of those domains, that's the right answer, whatever that is for you. And it's different, and there's so many places, and none of them are the wrong answer.
What phrase do you use? I've started using the phrase gun violence prevention instead of gun control. Is that
Gun
a good
violence
one?
prevention.
Gun
Yeah,
violence
gun violence
prevention,
prevention or gun safety, firearm
gun
safety.
safety.
Yeah,
Okay.
and try to pick one, because then it just becomes a habit. Yeah.
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 Have you ever, in your experience, do you know of any physicians who ever have gotten in trouble talking about this issue?
That's a really good question. I've had people tell me that they were in the past told not to talk about it. I mean, I was told don't talk about this. And also like specifically, hey, kind of when it was brought up, like this is unprofessional. But like actually formally censured. I mean, outside the state of Florida, I don't know if there were anything came out of the law from 2011, if physicians really did face consequences. So there's none that I know of specifically.
And I didn't know that law got overturned. I mean, I remember when I heard about that law, but I didn't realize it got overturned. And I would guess a lot of physicians don't know it got overturned. That
Yeah,
probably wasn't
yeah.
quite as publicized.
Right.
Um, let's see. I also wanted to agree with you about grammar. I'm also pretty pedantic about grammar. And then I don't know if you saw the Surgeon General's warning recently about parenting and how parenting is like a public health issue. I just feel like I felt like that kind of lessened. I feel like saying that parenting is a public health issue and gun violence is a public health issue kind of lessens the seriousness of gun violence. I mean, it's a little bit off topic, but I think in our messaging, it's really important to be clear, like you said, like that graph is so important. I don't know, any thoughts on that, how we can just be better at messaging?
Yeah, I mean, there's always I saw that report. I didn't read it. I haven't read it yet carefully. It all just comes back to that graph and how are we going to be able to live with ourselves? I mean, one of the things that I always say, like my son someday is going to ask me when he's older, Dad, I know you have these platforms and you do all this cool stuff and you're a doctor. Like, what did you do to make these things better? I need to have an answer I can live with.
Yeah.
And it boils down to that for me. This is where I live. This is my community. This is my country. This is my family. It matters to me that I can know that I'm trying to make these things better through a variety of different domains that are different for me than they are for each of you. And that none of them are right. And look, let me step back. They're all correct. Because it's the one that you're able to do right now. And they are all malleable. They can all change. You do something for a while and then you want to do something different. That's fine. It's a big opportunity. And that's again why I say like one of the kind of calls to action from this is for everyone here is you're in a research environment and part of our career is doing research and publishing papers and going to conferences and giving presentations. If this is stuff that fires you up, you should be doing that. And the opportunity to do it has literally never been better.
There's a big question in the Q&A about pushing for a constitutional amendment banning the right to bear arms, so overturning the Second Amendment. Have you engaged with that at all in your work?
I think that it's a big step to overturn constitutional amendments. And so we want to be really careful there. This is me just speaking personally.
Sure.
That being said, all of the interventions that are being promulgated right now are not in violation of the not in violation of the Second Amendment, and they'll be effective. So we want to make sure that we want this to be as inclusive as possible, right? All those people that are at polling at 80%. We want this to be as inclusive as we can. And I think that is a good and reasonable place to start. Conversations about types of firearms and what should be allowed and should be legal, that's a totally different conversation. When you poll about assault rifles available to the public, when you poll on that, the desire for the assault weapons ban to be renewed, that goes up and up and up every month. Every time you see it polled, that goes up and up and up. Should the public be allowed to buy weapons like AR-15s? That is, everyone's entitled to their opinion, but we had an assault weapons ban. We saw what it did to gun violence. And then we saw what happened when the ban was lifted. So I think that we have lots of opportunities to not change the Constitution, but make really significant, meaningful improvements for sure.
Yeah. So maybe not yet, but maybe that's a step by step.
Or maybe, who knows? I'm
Yeah.
not a constitutional law expert. But
in your spare time, you don't do that.
I also support the Second Amendment to the Constitution personally. I think that there are a number of ways that we can effectively intervene while still protecting the constitutional right to bear arms.
Well, I will just say before we go that I was wondering when you said that other things that might poll near 80%, I wondered if fans of Taylor Swift and or Beyonce might pull near 80%. That was the only thing I could think of.
That's a very good thought. Yeah, that's right. That's a great thought.
Well, thank you so much, Dr. Shapiro. Thanks to everybody for engaging and listening online. And Dr. Shapiro gave you all his information and offered to chat. So contact him if you need more information.
Thank you all so much. I really appreciate this.
Thank you. Have a great day, everybody.
Bye-bye.